So what we're going to do next is I'm going to demonstrate how I would do a flipped classroom model using the ECG lecture. And I've sent you the video of the ECG lecture. And if I was giving this in your classroom, this is how I would run it. So obviously this lecture is going to require a lot of participation. So here are the objectives of the ECG basics lecture that I hope you guys reviewed. So we are going to hopefully understand what the ECG provides us. Hopefully that you'll be able to recognize what happens with the depolarization of the cardiac cells, and that to recognize that electrical activity of the heart is captured by recording electrodes or leads placed on both the arms and the legs. Okay, so who can tell me what number 1 is?
SA node.
SA node, thank you. Who can tell me what number 2 is?
Is probably it is an internodal pathway.
Internodal pathway. Good. Who can tell me what number 3 is? Okay, I think Dr. Aman is trying to speak, but we can't hear him. Somebody else.
AV node.
AV node, thank you. All right, Dr. Aman, you might have to type in your responses. Okay, and who can tell me what number 4 is? Somebody.
Bundle of his or his bundle.
Bundle of his. All right, good. Who can tell me what number 5 is?
Right and left bundle branch.
Good. And then number 6? Purkinje fiber. Now, if you're a student that can cheat, the answer was down below. Good. All right. Great. Okay. Who can tell me what we're looking at and what is the significance of this? Okay. I heard automaticity. That's what I've heard. I think you have the right answer. It was hard to hear you. Dr. Blinn, are you on?
Yes, I am on.
Can you tell me what is it that we're seeing?
So on the left side, we can see the action potential of the ventricular muscles, and on the right side of the automatic cells. So it's the two action potentials of the two different cells.
Good. And what is significant about their difference?
So for the significance, those automated cells, they don't need any initiation for the start of action potential, but the ventricular muscles, they need stimulus for the start of the action potential.
Excellent. So that's the most important part that I want you to remember from this pictures is for regular cells, they require a stimulus to go from phase 4 to phase 0 and phase 1, whereas the automatic cells or conduction cells, their phase 4 has a slope. And without any need for a stimulus, that they're able to generate an action potential. So that is very, very important. So, you know, all these cells that you see, the SA node, the internodal pathways, the AV node, in the bundle of His, they have that's how the conduction goes through. So the SA node and the AV node, if you look at their slope, they have automaticity. This picture is a representation of where we get our EKG. So if you add up every electrical activity that's happening in the heart, including the conduction pathway system, when you add all those up in one cardiac cycle, the summation of that gives you the P, the QRS, and the T wave. Okay, so we've covered cardiac cell action potentials. Now we're going to focus on ECG lead placement. All right, so let me see, who can I pick on? Dr. Zamena, what are the names of these leads? This.
These leads are the limb leads, and the first one is lead 1, the second is just lead 2, and the third one is lead 3.
Excellent, good job. All right. Dr. Adana, what are the names of these leads?
Okay. Already it's augmented lead leads. That is in addition to the first 3 leads. This is the augmented one. So this more more can explain the, or it helps us to interpret the ECG more than the 3 leads.
Okay, I'm looking for the names of these leads. What's the name of the first one? What's the name of the second one? And what's the name of the third one? Who can help him? Anybody that can help him?
Okay, so the first one is AVR, the second one is AVL, and the last one is
Okay. So I think I heard you correct. You said the first one is AVR, which is, yeah. Good. So the augmented leads add, as you know, Dr. Edosa has said, it gives us more vectors. So the negative would be, Dr. Aman, were you saying something? Okay. But you got it right. You got the names right, and you said what they help us. And then, in addition to that, we have V1 leads, V1 through V6. This is how you would place it in a person. And this, again, gives you additional information of the electrical activity that happens in the heart. So any questions about ECG lead placements? Okay, good. Now, we're going to go to basic principles of ECG analysis. To me, this is probably the most important slide from all the talk. So I hope you captured this information. So let's say you have these cells lined up here, and they depolarize from the left to the right. And this is the direction of your vector. So the electrical activity goes in this direction. So if you place lead A with the negative charge over here for lead A and the positive on that side, when you look at your ECG tracing, this is what you get right here. Can you guys see my arrow or no?
I can see.
Yes.
I can see.
Okay, good.
For me, yes.
Oh boy. I'm sorry, I didn't hear you very well, Dr. Adana, but it sounds like you guys can see it. So lead A, if we place minus to plus on the ECG tracing, we will get a positive deflection. So the same electrical activity, if we place lead B where the negative is on this side and the positive is on that side, what would our ECG tracing look like?
Downward deflection.
Downward deflection. Thank you, Dr. Blinn.
It is a negative deflection.
Negative deflection. So the electrical activity didn't change. All that changed was we switched how we were going to see the electrical activity and we get a downward deflection. So the same vector again, if we place lead C up and down where we have negative and positive, what would we get on our ECG tracing?
Asystole or just horizontal line?
Horizontal. Okay, let's not use the word asystole because asystole has a clinical implication, but I know what you're trying to say. It will be a horizontal line. You will not detect any electrical activity in that line. So really, really, this is a very important concept. So the same electrical activity that's happening in the heart, depending on which direction you look at it, you will get a different representation on the ECG tracing. So really, all we do with ECG tracings is we place leads, we look at the electrical activity from different angles, and we learn what is normal. We memorize what normal looks like. You know, what does lead 1 look like in a normal person? What does, AVR look like in a normal person? What does V1 look like in a normal person? So there are 12 leads that in a normal person, in an appropriate placement of ECG, there are tracings that are expected. And then when someone has an abnormality, when the electrical activity changes, then we detect it based on the change that we see. So it's really pattern recognition is all ECG is. Okay? So a very good clinician would memorize what lead 1 would look like in a normal person, what lead 2 morphology looks like in a normal person, what lead 3 looks like in a normal person, so that when something looks different, they can pick it up. Okay, so a typical, 1 cycle, cardiac cycle has a P, QRS, and T, and then there are normal levels of the intervals. So you have the PR interval, the QRS interval, the QT interval, and then the ST segment. So what is a normal PR interval? How long should the PR take?
Um, 0.12 up to 0.2.
0.12 to 0.2. Okay. Seconds, right?
Yes.
Is that right?
Yeah, or 3 small box to 5 small boxes.
Good. Good. That's right. Good. How long should a QRS be? QRS interval in a normal person?
Up to 0.2 seconds.
0.12 seconds or 3 small boxes.
Yeah.
Great. Okay, so here are the so the PR interval should be between 0.12 to 0.2, 3 to 5 small boxes. QRS should be, between 0.06 and 0.12. QT should be less than 0.144. And again, this is pattern recognition. When this pattern changes, you know that the patient has some abnormality. Okay. So determining heart rates. So who can tell me what's the heart rate for the first patient in this tracing?
So can I react it?
Yes.
So generally, we can see the some principles. So the first is we can divide 300 to the large boxes between the R wave. So we can count this 1, 2, 3, 4, 5, 6, 6.5. So we can divide 300 by 6.5.
Let's say 7.
Yeah. Okay.
Let's make it easy. Let's say it's 7. Let's round
Yeah.
to 7.
Yeah, we can divide 300 by 7.
Good. Okay. How about this one, the second one? Somebody else.
Okay, me.
Uh-huh.
Okay, thank you. First of all, it seems regular rhythm, that is sinus rhythm.
Mm-hmm.
So to determine their rate, we should count the large boxes between two QRX complex, which is around 2 and it's difficult to say 2.5, but around more than 2. So approximately 300 divided by 2 and 2 point something, around 130.
I like it. I like it. Good. One more. One more. Who wants to do the last one? The third one.
It is 60.
60. 1, 2, 3, 4.
Yes.
300 divided by 4,
Well,
about 75.
1,
Okay.
1, 2, 3, 4. Oh, as not actually. Yeah.
That's fine. But you guys get the point, right? Okay.
Yes.
All right. So I'm going to stop. Okay.
7, yeah.
Obviously, you guys know about, ECGs and so forth. The whole point was to demonstrate how you would run a flipped classroom model. Okay, so to summarize, this is an instructional methodology. It does require people to recognize what you're doing, to understand what you're doing. So you have to be intentional about setting expectations to let them know. I think it is extremely beneficial, especially if you have to cover things that require applied knowledge, very complex thinking. Have the students cover the basics at their home, and then in the classroom, be able to cover those complex cases. You don't have to flip every single classroom that you give, but you can be selective on how and which classes you utilize this method. Okay.